So the purpose of my presentation this time is to tell you about a new device which has just been developed through a collaboration with some partners in Newcastle and Sydney, and the prototype's ready now to start trialling in a research project. And before I do that though, in order for you to understand the principles on which it's proposed to work, I'm going to take a step back and talk about some of the principles of recovery and why this type of device is needed. Okay, so Melissa really covered this, but really what we're talking about is why do we even need technology in upper limb rehab? And really the statistics tell the story. So we know how common stroke is. Over 55,000 people had a stroke in Australia last year, and 2/3 of those suffered from arm weakness as a result of that. 3/4 of them. And we know that of those 3/4 of 55,000 people, that 2/3 of them will not regain full use of their arm. And that's despite maybe receiving intensive rehabilitation therapy. So we know that what we're currently offering is inadequate. We need to continue to search for better therapy options for our patients so that we can maximise recovery. And that's what we're doing with the use of technology. And we know that there's going to continue to be more and more strokes as we as a population continue to age, because age is a risk factor for stroke. So it's not a problem that's going to go away, it's only going to get worse. So we need to continue to strive to find better therapeutic tools for our patients. So we need to think about what we do in therapy and what we know about what works in therapy so that we can try and build that into the technology that we're developing. And you know that when you have a stroke, you lose blood supply to your brain, and then that area of your brain dies, and those cells do not regenerate. That's a dead spot in your brain that will continue for the rest of your life. It will not receive any messages from your body, and it will not send any outgoing messages from that section of your brain. And we always talk about this term neuroplasticity. And what that means is we've got this dead spot in your brain, so we need to look for other pathways to try and take over those roles that have now been lost. And in this diagram you can see a fancy MRI scan called a connectome that really gives you a good pictorial representation of the density and the complexity of the connections in your brain. And you can see that dead spot there. Nothing's coming in, nothing's going out. So some of those fibres around it are now going to have to take over those functions. And you've probably seen this diagram before. This is called the Homunculus, and it's a pictorial diagram of the areas of your brain that are dedicated to different parts of your body. And the interesting thing to note is that, you know, your brain isn't divvied up equally. The amount of space that's given to specific parts of your body is determined by the specificity and the importance of those body parts. So in your brain, we have the largest representations for your hand and your mouth. And that's not really surprising, because those two functions are what makes us uniquely human. The ability to articulate language and the ability to manipulate tools. So our brain has already designated the biggest parts of it to those areas. So if you had a stroke that affected the arm and hand area of your brain, then essentially what we need to do is to get the surrounding areas to take over those functions. That's what neuroplasticity or re-networking is. And the only way you can do that is to drive that change in your brain is through therapy and practice. And as Melissa was saying, the way that you need to do that is through lots of repetitions, high volumes, high intensity practice, and it needs to be task specific. So if you want your brain to relearn new jobs, then you need to tell it that it needs to do that through lots of practice. It's a bit like a muscle. So if you want to strengthen your biceps, then you need to put a load on it to make it strengthen. And if you don't use it, in a way that requires that strength, then you'll get weaker. So your body will continue to adapt to the demands that are put on it, and so does your brain. And interestingly, it's not just in response to injury. Your brain is changing every day. Every time you think something, connections are changing. So even though we say we need to, front load rehab in that first 3 months because that's when you get the most benefit, but we now know that it doesn't matter how far past your stroke you are, you can still get benefit if you engage in therapy. You can still change those network patterns in your brain. It becomes harder, but it's still possible. You just need to put the right demands on your brain. And the other thing is that we know, in addition to high volumes, high intensity, the practice needs to be task specific. So if you want to learn how to reach and pick up a cup again, then you need to practice those specific components. You can't just practice strengthening your triceps because your brain doesn't store movement patterns that way. So for me to reach and pick up a cup, not only do I have to turn on my triceps, but I have to turn off my biceps. I have to turn on my wrist extensors. My hand will already be open by the time it reaches the cup. So all of those things happen in a sequence. So I can't just practice strengthening an isolated muscle because that's not going to help me improve my function. So when we talk about task-specific or functional retraining, that's what we're talking about. We need to practice the components of the function you want to improve because that's the way that we store movement patterns in our brain. So Melissa's already talked about some of the limitations of the therapy that we already offer. It's labour intensive, it's time intensive, and more importantly, it's boring. I'm sure most of you have been in therapy where you've had to move beans from one cup to another over and over, and it's very hard to maintain any motivation for any period of time. And if you want to change your brain to be able to do that, you're going to have to do that lots of times. So often motivation dies before the potential for recovery does. Yep. And it becomes even more difficult if you have a lot of weakness. So if you can't actually perform that and you need assistance, well, that assistance might not be available. And if you continue to fail at that task, then it's even more demotivating. So there's been a few advances. Essentially, we've been doing the same things in rehab for the last 40 years, and I know Melissa and I have been chatting about how exciting it is to be working in rehab at this particular time because there's so much hope that there's new advances on the horizon, and we're exploring all these new avenues to help recovery. But we still are really at the beginning of this journey. But over the last 10 or so years, there's been some advances. Probably the earliest one was with electrical stimulation, and some of you may have experienced this in your own rehab. And it's really just placing surface electrodes over the muscles. Your brain can't stimulate those muscles anymore, so we can do that with electricity by placing electrodes on the surface and giving them a jolt to get them to contract. So we've been doing that for a while. In its simplest form, it's as pictured there, just with using a TENS machine to stimulate muscles. There are a lot more complex devices which are now available. What we do know is that it needs to be used in a functional way. So just as it's set up in this diagram, the stimulation is set to assist the functional training. Another recent advancement is this idea of haptic feedback, and we're just learning more and more about the importance of sensory feedback to help functional retraining. And in the way that it's being administered nowadays is generally through a glove or a hand device, and it's just providing some sensory stimulation to the hand generally while you're performing some computer-based activity. And we know that sensation is really important for movement because it guides what the contraction or the muscle force that we generate. So if you look at the picture of the 3 cups there, essentially you need to do the same motor output, you're reaching and grasping, but depending on which of those cups you're going to pick up, then the force that you generate is going to be very different. So if you're picking up the plastic light cup, then once your hand touches that cup, you get some sensory feedback to your brain to tell you how to remodel your force so that you don't, the cup doesn't slip and drop, but also so that you don't squash the cup and break it. Right? And if you picked up the heavy metal cup, then the sensory feedback you get when you initially pick that up will then remodel the force that you generate in your hand so that it's appropriate for that weight and that size. So sensory feedback is really important in helping us to learn motor output. And then the other type of innovation has been virtual reality. And since the development of We Fit, there's been this growing interest in putting virtual reality into rehab settings. There's essentially 2 different types, and this is this kind of gaming application where essentially these 2 ladies are playing tennis and they're manipulating the people on the screen by their own hand movements. The other type of virtual reality is called immersive virtual reality, and that's generally administered through goggles or a visor, and the person is immersed in the artificial world and they perform tasks in that environment. There's lots of advantages with virtual reality in that it can be more fun than your normal based therapy. You can compete or play with other participants. It can be very goal-based, so you're trying to achieve a goal that is very visible to you. There's an endpoint, which is often very helpful as well for motivation. And you can set the challenge specific to the individual's level. So there's lots of advantages to VR. But now engineers are developing this new generation type tech, and the device that I'm talking about is incorporating these components. So it's immersive virtual reality that's administered through a headset. It's got EMG triggered stimulation, so you wear a glove device. It has electrodes in that glove device so that when you initiate the movement to try and perform the functional task, it will provide some electrical stimulation to help facilitate that movement. And it also has other sensors in the glove to provide you with the sensory stimulation related to that activity. So for example, if the virtual task you were doing was to wash your hands under a tap, you would get the sensation of the warm water on your hands as you're performing that task. Okay, so let's have a look at the device.
Bathroom with all the modern assets, light and shade, designer fittings, a sought-after wardrobe. It's virtually reality.
I'm in this beautiful bathroom and I'm about to learn how to brush my teeth all over again.
For stroke patient Steph Ho, this world is part of a new and improved treatment.
I'm about to approach the toothbrush and try and pick it up. And I have it, I can feel it, and I'm about to brush my teeth.
It's engaging and completely immersive, a long way from tried and traditional therapies.
As a 22-year-old kid, I had no idea what a stroke was. I also didn't know what I needed to do and just how much was required of me to even get anything back.
More than 50,000 Australians have a
So just to talk about the research, it's about to start. We're going to run the trial out of 3 centres. There'll be a site in Sydney, there'll be one in Tamworth and one in Newcastle. To be eligible to be a participant in the trial, you need to have some loss of function in your arm, but you need to have a little bit of movement in your arm because you need to be able to initiate some movement for the electrodes to pick up that initiation of movement. You need to have limited contractures in your hand because we need to fit your fingers into a glove. So if we can't open your hand, then you will be ineligible as well. And the other criteria is that you can't suffer from motion sickness. So if you can't read in a car or you can't go on a boat, you're probably not going to like the experience of virtual reality. And so just to conclude, technology is definitely going to play a part in rehab in the future, but it's really important that we conduct some research trials to make sure that therapists and patients can guide the development of that technology. So I'm really, really relying on patients' inputs to make sure that the technology is developed in the way that you want it to be in the future. Thank you.